So actually this talk kind of builds, I think, nicely on the last two talks, because a lot of the techniques that Nick and Stefan talked about are useful in ostial CTOs. Can we bring up my slides, please? Okay. So here are my disclosures.
All of them.
So this talk is about treating ostial CTOs. Again, here are my disclosures. Just to start off, this is a paper that was published last year by Manos, looking at 1,000 consecutive CTO patients. It showed the frequency of ostial CTOs. In this registry, about 17% of all CTOs were ostial, and about half of them were aorto-ostial, and the other half were side branch ostial occlusions. The majority of these were treated retrograde, but they had similar success rates to non-ostial CTOs and similar MACE rates as well. One of the things that was found with those is that the ostial CTOs were more likely to be long CTOs, were more likely to have proximal cap ambiguity. They were more calcified, more distal disease, more prior CABG patients, and more cases that had usable interventional collaterals. So we generally divide ostial CTOs into two categories. There are aorto-ostial lesions and side branch ostial lesions. Aorto-ostial lesions can be very challenging because there are very limited antegrade options, particularly if there is no stump. Aortic entry from a retrograde approach most commonly is done with retrograde wire escalation. Oftentimes, stiff penetrating wires are needed to kind of puncture through the aortic wall to get into the aorta. Knuckle wires have been used occasionally to go into the aorta, though oftentimes the knuckle wires will travel up the aorta, so you need to make sure that this is viewed in several planes to make sure that you're not just traveling along the wall of the aorta before your microcatheter is then advanced. And then last, most recently was described by Bill Nicholson using electrocautery to electrify a wire, which can help re-enter that last few millimeters to get into the aorta. Side branch ostial lesions, oftentimes the retrograde approach is the preferred approach with retrograde wire escalation to re-enter into the main vessel. Another approach that I've used on occasion is balloon-assisted subintimal exit, where a balloon, preferably a cutting balloon, is inflated in the parent vessel to create an opening between the true lumen and the subintimal space that will help with retrograde rewiring. Antegrade options also are available in this particular type of ostial CTO. You can use the IVUS to guide cap puncture, or you can go retrograde with a wire or Carlino to define the course of the vessel to help guide an antegrade puncture. So we're going to go through some cases that kind of highlight some of these techniques. It's a case I did a couple years ago. A lady who had previous stents in her right coronary artery, and it was occluded at its ostium. The right also had an anomalous kind of high anterior takeoff, and it was very difficult to engage with any catheter. We were able to go retrograde through a septal relatively quickly, and then wired back up towards the mouth of the vessel really quite easily. And because we had the guidance of the previous stents, we were able to wire into the aorta relatively quickly with a jacketed wire. With aorto-ostial lesions, you obviously have to be very good at retrograde techniques. You need to know how to snare in the aorta because it's very difficult to wire into the guide, particularly if you don't know where to place the guide. So we were able to rewire the vessel and then use laser atherectomy, PTCA, and stenting to get a reasonable result. This is a case I did several years ago. It's a gentleman who had had a previous bypass surgery, and at his bypass they used a gastroepiploic artery for his right. He had had a gastric bypass surgery about 3 or 4 years ago, and you can imagine what happened. They clipped the wrong vessel. He ended up having an inferior infarct, fortunately survived it, but survived to have class 3 angina that was really unremitting despite multiple drugs. And so I brought him in with a plan of doing a retrograde approach. He had a flush occlusion of his right. We were able to get retrograde relatively easily. We got a microcatheter all the way back around. I actually did a tip injection, which could highlight the location of the occlusion. And you can see it was a very short occlusion. It was only about 3 or 4 millimeters. I tried multiple techniques to get through that, but could not get through into the aorta. I actually dissected up the aorta with a knuckle wire. At one point, I think I had a confianza wire in the pulmonary artery, and eventually I gave up because I just didn't have any other solution at this time. And so before I finished, I did do one more retrograde picture, and you can see I had created quite a bit of dissection right at the ostium of it. And I brought him back about 3 or 4 months later after I had been told about how to electrify a wire, and I was thinking of going with electrocautery on this. But when I brought him back, the vessel was actually open. So sometimes if you just damage an artery enough, sometimes they'll heal in a favorable way. So we were able to wire it in about 2 minutes and get it stented. So here are a couple of side branch ostial CTOs. This is a case I did a couple years ago. It's a gentleman who had a previous bypass and had an anastomotic lesion on the circumflex. And previously it was noted that his circumflex was actually also retrograde filling a ramus branch, which was no longer filling. And he was having significant anginal symptoms. And so we went retrograde down the graft fairly quickly, and we were able to get up to the proximal part of the circumflex. At this point, I had some difficulty getting into the circ system, and so I took a cutting balloon initially in the left main to try to create some channels so I could get something subintimal. We then eventually pushed this into the LAD and inflated it there and used it as a blocking balloon. And on the left-hand side, you can see I was able to get a knuckle going that then was starting to travel out the ramus branch. We then did a star of the ramus branch, which you can see on the right. You can see the wire jump. And then because we had dissected the left main fairly well with our cutting balloon, we were then able to rewire back from the circumflex into the guide and then finish the case. This next case is a gentleman I took care of a couple times over the last few years. Previous bypass surgery, had a vein graft to the circ system and had a vein graft to the LAD. And he had multiple vein graft failures over the last 10 years or so. A couple years ago, I fixed his left main into his circumflex because of multiple vein graft failures. And he came in again with another vein graft failure to the LAD. And so we were going to fix this. Now this was made more difficult because we could not see the ostium of the LAD, and intravascular ultrasound wasn't really helpful because of the stent was covering the ostium of the LAD. So we went retrograde down the vein graft, and we were able to kind of identify the location of the vessel by doing a tip injection using the Carlino method. We punctured in with an Osteo to get through the distal cap. We got the tip of the microcatheter into the plaque. I couldn't knuckle a wire at this point, partly because I was just getting pushed back down the LAD. But the Carlino not only dissected it, which helped us to identify the course of the vessel, but it also softened the plaque that then I was able to get a retrograde knuckle going, and we were able to knuckle back up towards the left main. Our knuckle wire was obviously subintimal and outside the stents, but we were then able to spin our microcatheter retrograde, and we had a very nice target to do an antegrade puncture. We used an Osteo 20 to do an antegrade puncture through the wall of the stent strut into the LAD, following the track of the retrograde gear. And then after stenting, got a nice result of the LAD. The next couple of cases are cases where intravascular ultrasound was helpful in determining where the ostium of the vessel was. This is a gentleman who'd had multiple end STEMIs because of, it was felt to be because of thrombosis in this aneurysmal graft with embolization. You can see the obtuse marginal branch origin is completely ambiguous. We were able to get retrograde down the graft and knuckle a wire right up to the AV groove circumflex, and then we put an IVUS catheter distally, and we were able to see the retrograde wire. Now, because there was so much calcification in the native AV groove circumflex, we still couldn't really see the true origin of the obtuse marginal branch, but what we could see was the wire in the subintimal space. So that gave us a target that we were eventually able to puncture in, get a knuckle going down the obtuse marginal branch. We did a spin fluoroscopy just to confirm that we were in the architecture, which we were, and then we were able to get this fixed. We then put a coil in the distal graft and then a vascular plug in the proximal graft to exclude the aneurysmal vein graft. And finally, this is a case I did a couple months ago. This is a gentleman, a relatively young guy who had really unremitting class 3 to 4 angina, couldn't do his job as a delivery driver because of his severe symptoms. He was cathed a couple years ago and was found to have an occluded diagonal branch. He had a large area of anterolateral ischemia on a stress test. This previously had been attempted twice. The first case, the operator couldn't even find the vessel to poke at antegrade. The second case, the operator was able to puncture into the vessel and tried to star into the distal vessel, but his wire never went into the true lumen, so the gentleman was referred to me for consideration of another attempt. Again, you can see it was, the distal vessel was filling very poorly, which was going to make a dissection reentry somewhat challenging just because we didn't have great distal vessel visualization. We eventually used IVUS to do real-time cap puncture, which Nick showed earlier. Here you can see we needed an Osteo 20 to puncture through the cap. We were able to get that into the vessel. And then the IVUS on the right shows that when we did the pullback, you can see the wire coming in right there through the vessel. And at this point, I felt fairly comfortable in spinning my microcatheter through, knowing that I wasn't going to exit the vessel. We then went to look for a retrograde channel, which was off of a fairly poorly defined epicardial off the distal circ, which we were able to fortunately wire retrograde. Again, this was done only after an extensive informed consent, given the high-risk nature of this epicardial. And with this, we were then able to rewire into the vessel, back into the LAD using a reverse cart, and we got an excellent result. So ostial CTOs are relatively common in contemporary CTO practice, and they present some unique challenges. Really, you have to have a mastery of retrograde techniques to be able to open these CTOs. Retrograde reentry into the true lumen most commonly is used with retrograde wire escalation, but E-cart, knuckle star, or balloon-assisted subintimal exit can be helpful as well. And real-time IVUS imaging is helpful to gain antegrade access in a safe manner.
That's great, Jason. Thank you. Bill and Jason, could you talk a little bit about troubleshooting E-cart using a angled microcatheter? It's relatively new. I've had those of us that have been trying have sort of worked through some tips and tricks that work there.
Jason, E-cart? You want to talk about E-cart? Go ahead.
You go ahead. You know more about it than I do.
I don't know about that. I mean, I think the key is one, the important things about E-cart, you can't use metallic catheters. So if you're using a Corsair or a Turnpike, you really need to swap it out for a plastic catheter, which is usually a fine cross, just because otherwise the electricity goes into the metal as you do it. I actually melted the tungsten on a Corsair doing an E-cart longer than you're supposed to. I think you can try and use angled microcatheters, but usually they're hard to get retrograde. When Suzuki comes out, you might be able to use a dual lumen to help you sort of redirect. I would also tell you is don't be afraid to do a stick and swap. That we've done one where we stuck out in the Ordo and didn't get a good feel with the wire, and I just swapped it for a Pilot 200, and the Pilot went out and did well. I had a third case where you're only supposed to do 50 cut, and you're supposed to do it for less than a second. So I did 100 cut for 2 seconds, and I melted the wire into the aortic wall. So we had to sort of biopsy the aortic wall. The good news is it changed the plaque compliance and was able to put it out. So there are some solutions to managing this. The one thing that Jason didn't bring up, and I think people continue to forget about, is cart. These are great situations to take retrograde balloons. So taking a retrograde balloon to the aortic ostium and blowing it up and making big space and use that to puncture antegrade with. And the same in some of these eccentric circs and through vein grafts, et cetera. Don't forget sometimes to change directions, because a lot of times it's easier to manipulate the wires antegrade than it is retrograde, and you can change the plaque compliance much more significantly with a retrograde big balloon than you can with just a knuckled guide wire. So I would just add that into people's troubleshooting is don't forget to take balloons retrograde. It actually is an effective tool.
So the e-cart, it does not have to also go retrograde. Sometimes you just use your retrograde. Now you can figure out you have retrograde knuckle. You can actually e-cart integrate or e-cart retrograde. If you, but if the retrograde e-cart is very ambiguous, you can actually just e-cart integrate. And a lot of times, what happened, the electricity will modify the plaque. You'll be able to cross from the other end. And we've done that several times where we can e-cart and then the wire from the other end actually crossed easier. So the next, anybody, do you have a comment? Go ahead.
I think from a diagnostic perspective, it's very important for you to, if you're dealing with a post-CABG patient, just read the post-surgical patient, just read the report adequately. I had a narrow to ostial case that I got retrograde. I just did everything, Carly, no wire, nothing would get into the aorta. He had a bioprosthetic valve in the aortic position, and when I read, it was a bental. So I understood why I was not able to get into the aorta, but it could have been avoided by reading more appropriately the report.
And you could e-cart through that, can't you, Bill?
We've not had the need to try it yet. It's been discussed.
Yeah. Okay. So that's awesome. And sometimes you get a consult for CTO and do CT, and you find the SVG widely open to that vessel, but they just couldn't find it. That's another reason to read the report. So coiling. Let's go down the panel. Mitul, when do you coil, when you don't coil?
Yeah, so it's an interesting question. We just talked about that in this challenging case session that Jason and I were in. It really depends on how much flow it's providing to the native. I mean, if it's a tight graft that's providing limited flow, you've used it to go retro, you may not need to coil it. I think if it's providing competitive flow, it's probably worth coiling.